It's possible to see the screen.
Yeah. Nice.
Thank you. Very good evening to you one and all. Namaste. I am very much thankful to the organizers for this session. Let us start. Today, in this first session, we shall discuss more about the applied anatomy of knee joint. And then later we shall discuss about the patellar tendonitis, Chondromalacia patella, Iliotibial band syndrome, etc. This quote to all dear doctors, you were born with the ability to change someone's life. Don't ever waste it. Before starting the class, I would like to pay homage to our dear Guru, Vaidibhushanam Padmabhushanam Raghavan Tirunelpadu sir. Why? Because in 2019, India government selected his name, and as a part of homage, Postal Department made a stamp in memory of Raghavan Tirunelpadu sir. And presently, a hospital is being building at Chalakudi in memory of him. It's by the central government and it is specialized in Shalakya department. Actually, Tirunelpadu sir wrote almost 42 books in his lifetime. And so, in his lifetime, he was a good guru, and presently also through his books, we can follow him. His practice was purely scientific and ethical, and we shall follow his pathway for a better tomorrow. Coming to the applied anatomy of knee joint. As all of us know, knee joint consists of total 3 articulations: medial tibiofemoral joint, lateral tibiofemoral joint, and one patellofemoral joint anteriorly. This applied anatomy, the knowledge of applied anatomy is very much important in the diagnosis and management of knee joint disorders. As knee joint is a very large joint and it is more prone to injury, but today's session we are discussing about the pathological aspects of knee joint. And after spine, most of the cases coming to Ayurveda OPD are of knee joint. The precise diagnosis is of very much important in the management also, to avoid recurrence and to get complete relief. That is very important, to get complete relief without recurrence. That means Shuddha Chikitsa. For that, the knowledge of applied anatomy is of utmost importance for the diagnosis of knee joint cases. I repeat, after spine, after cases of lumbar spine, most of the cases coming to our OPD are of knee joint. And today's discussion topics, that means bursitis, patellar tendonitis, Chondromalacia patella, ITBS, iliotibial band syndrome, such cases are very common, and most of the cases we miss the diagnosis. For avoiding recurrence of ITBS, iliotibial band syndrome, which is very common in marathon runners, and also which is very common in rickshaw pullers and in farmers who are above the age of 50, who are walking uphill and down. In such cases, if the patient needs to continue that activities, that means for a sports person in between the age group of 15 and 30, for that patient to continue the activities, that means to continue the sports activities, definitely we shall learn the diagnosis, proper diagnosis, by knowing the applied anatomy, and we must give rehabilitation to avoid recurrence. Okay, coming to applied anatomy, as we all know, actually it consists of one medial tibiofemoral joint, lateral tibiofemoral joint, and one patellofemoral joint. And the knowledge of this patellofemoral joint is very much important in the management of Chondromalacia patella. And we shall go through the slides, some pictures to get a complete knowledge of these structures. And this is the largest joint. I already explained that. knee is a modified hinge joint. In Ayurveda, that is in Susruta Sharira 5th chapter, Janu is considered as hinge joint itself, that is Kora Sandhi, and it permits flexion and extension. The two main movements in knee joint is flexion and extension. In elbow, there is supination and pronation, but in knee joint, there is no such movements. There is slight internal and external rotation, but it is not of much significance when compared to elbow joint. But this external rotation and internal rotation is only possible when the knee joint is 90-degree flexed. If you are in a sitting position, you can feel the internal rotation and external rotation of knee joint if your knee is flexed to 90-degree. All of you can feel that particular movement if you are in a sitting position and the knee is in 90-degree flexed position. You can feel the internal and external rotation of knee joint, but it is a very small range of motion and it is not significant in the management or in the diagnosis part. But these movements, flexion and extension, regarding if we are managing orthopedic cases, the two things we must keep in our hand for the better understanding and diagnosis of case. One is a tape, measuring tape. If we want to check whether there is quadriceps wasting, we must have a measuring tape to measure the exact difference of quadriceps wasting. If a patient comes to OPD with an old injury, nearly 1 year old injury of knee joint, and if the patient is not done proper management for that particular condition, if you check the case of wasting of quadriceps muscle, wasting can be measured from the superior pole of patella. We can measure a distance of 10 centimeter upwards, and in both knee joint we can check. First, definitely in orthopedic OPD, actually the basic of orthopedic clinical examination is Darshana, Sparshana and Prashna. Darshana means inspection. In inspection itself, we can see the wasting, and second one is palpation, and the third one is Prashna, that is asking the patient to do the range of motion. Regarding knee joint, flexion and extension, we are checking how much the flexion and extension is possible. And look, feel and move, that is another tool to do this clinical examination. That is same, look means inspection, feel means palpation, and move means to assess the range of motion. For measuring the wasting, we are using the measuring tape, and definitely if a patient with 1 year old injury to any particular structure of knee joint and the patient is not undergone a proper management, definitely there will be a wasting of muscle from 2 centimeter to 4 centimeter. 2 to 4 centimeter difference will be there. After further clinical examination, we shall advise the patient to do some rehabilitation, and on the next review after 2 weeks or 4 weeks, we can again check the difference in the wasting of muscle. That is the need of documentation, and this documentation is very much important in the management of orthopedic practice. First one is measuring tape, definitely we must keep in hand, and the second one is a goniometer to measure the range of motion. With a goniometer, we can easily assess the range of motion, flexion and extension, and we shall note it as part of documentation. If a patient with Chondromalacia patella come to OPD, a patient of age, a 40-year-old female patient come to OPD with severe pain. Why? Because that patient may have more weight, around 90 kg of weight, and the patient started immediately squatting, lunges, etc., such exercise, or walking to reduce the weight. Immediately the patient started severe anterior knee pain, and the patient is unable to walk. In such situation, if a patient come to OPD, that patient's flexion will be very much affected. If we measure the flexion, range of motion of flexion with a goniometer in the first OPD sitting, after 1 week when the patient come after management, definitely we can again check the range of motion. If the patient follows the patya advised by us, and then if she took the medicine properly, then definitely the range of motion will be complete within 7 days. And we can assess that range of motion also. That is the beauty of documentation. So that regarding knee joint, also remember, Janu, Marma injury causes Kanjada. Kanjada means limbing. An injury to particularly Janu Marma causes limbing to that particular affected knee joint. That is the Lakshana explained in Susruta Sharira 6th chapter. And so that as part of orthopedic clinical examination, definitely we should follow this protocol, look, feel and move, and we shall keep a measuring tape and also a goniometer to assess the range of motion and to measure the difference in wasting. And another thing, definitely in all orthopedic clinical examination, first we should examine the normal knee joint. First we should examine the normal knee joint and then the affected knee joint. I request all of you to mute. I request all of you to mute. Thank you. The first thing in clinical orthopedic setting is first we should do the clinical examination of normal knee joint and then the affected knee joint. Okay. And this knee joint is vulnerable to injury and also to the development of osteoarthritis and other pathological conditions which we discussed today. Okay, we already discussed this particular from the very first point. Coming to the ligaments, there is intracapsular and extracapsular ligaments in knee joint. And the intracapsular ligaments of knee joint include anterior cruciate ligament, which prevents the forward sliding of tibia. And I will show the picture of ACL. And next one is posterior cruciate ligament. Both are in this position, so that it is called as cruciate ligament, ACL and PCL. And there is one transverse ligament, which is intracapsular, which connects the two menisci. And extracapsular ligaments includes patellar ligament, which connects the patella to tibial tuberosity. Medial collateral ligament, which consists of interior and exterior part. Medial collateral ligament is connecting the medial epicondyle of femur to the medial part of tibia. And there is lateral collateral ligament, which is connecting the lateral femoral condyle connecting to the fibula, upper end of fibula. Injury to lateral collateral ligament is of very much important. Why? Because there is a potential risk when there is injury to lateral collateral ligament. Why? Because the most common site of injury to lateral collateral ligament is at its distal part. Distal means away from heart and proximal means near to heart. And the distal part of lateral collateral ligament is attached to the fibula, proximal end of fibula, upper end of fibula. And whenever there is injury to lateral collateral ligament, there is a chance of avulsion, and so that there will be fracture to the proximal part of fibula, which may cause injury to common peroneal nerve. That particular injury may cause injury to common peroneal nerve injury, which in turn causes foot drop. So that particular injury, I repeat, the injury to lateral collateral ligament occurs at the distal end, that is at the attachment of proximal end of fibula, and that particular injury may cause common peroneal nerve injury, which in turn causes foot drop. So that particular injury is of potential risk, but that injury is very much rare when compared to medial collateral ligament tear. Regarding medial collateral ligament tear, as part of applied anatomy, I am explaining these things. Medial collateral ligament injury more commonly occurs at its femoral attachment. Medial collateral ligament injury is more common when compared to lateral collateral ligament, and this medial collateral ligament injury occurs more at its proximal end, that means at its femoral attachment. And this patellar ligament injury is rare. I will explain it in later. Coming to ACL and PCL, anterior cruciate and posterior cruciate, anterior cruciate injury is common. And if there is a patient with ACL tear, we diagnose it with Lachman's test. In that particular condition, the most appropriate time to take MRI is after 3 weeks and before 6 weeks. The most appropriate time to take MRI in intracapsular ligament tear is after 3 weeks and before 6 weeks. Whenever there is a complete ACL tear and the patient comes to us regarding second opinion for surgery, if it's a complete tear, then it's better to go for surgery. Why? Because if the patient continue to walk with a complete tear of ACL, surely there will be injury to PCL also, posterior cruciate ligament injury also. And the repair of PCL is very much costly when compared to ACL. If the ACL repair costs on an average of 1 or 1.5 lakhs, the PCL repair take 2.5 to 3 lakhs. So that if the patient with complete ACL tear continue all the activities without proper doing rehabilitation, it will end in tear to PCL also. So that if a patient come to us for a second opinion regarding surgery of complete ACL tear, it's better, if we are thinking from the patient's aspect, it is better to go for surgery. This is the picture. Please note, these structures should be in our mind while we are doing the clinical examination. This is very much important. This is the lateral femoral condyle. Hope you can see. This is the lateral femoral condyle from which the lateral collateral ligament or fibular collateral ligament is attached to the proximal end of fibula. Here we can see that this lateral collateral ligament has no attachment with the menisci. But in another picture, we can see that medial collateral ligament at the other side is closely attached to the medial meniscus. So that there is an unhappy triad, which a particular injury in which there will be tear to medial collateral ligament, medial meniscus, and anterior cruciate ligament, which requires immediate surgical correction. I repeat, unhappy triad means there will be tear to anterior cruciate, medial meniscus, and medial collateral ligament. And when compared to ACL and PCL, here we can see that anterior cruciate ligament is attaching to the anterior tibial plateau. Here we can see it is attaching to the anterior tibial plateau and to the lateral femoral condyle, towards the lateral femoral condyle. But here we can see the posterior cruciate, which is situated posteriorly and is attached to the posterior tibial plateau and towards the medial femoral condyle. So it is actually, it's cross-shaped, so that it is known as cruciate. ACL is attached to the anterior tibial plateau and towards the lateral femoral condyle, and PCL is attached to the posterior tibial plateau and towards the medial femoral condyle. This is meniscus. This one is lateral meniscus. This picture is of left knee joint, and this one is the medial meniscus, we can see. And actually this meniscus is vascularized only at the periphery. Please note, this meniscus is vascularized only at the periphery. At the internal part, that structure is avascular, and whenever there is an injury to this particular area, that means to the avascular area, it won't heal. Why? Because it's avascular. The internal part of menisci is avascular and the external periphery part of menisci is vascular. Please note. And this is the quadriceps tendon. From proximal to distal, the extensor apparatus of knee joint. Please note, from proximal to distal, the extensor apparatus of knee joint consists of quadriceps muscle, quadriceps tendon, patella, and patellar tendon. I repeat, the extensor apparatus of knee joint consists of, from proximal to distal, quadriceps muscle, quadriceps tendon, patella, and patellar tendon. See the patellar tendon. Patellar tendon is attaching from the patella to the tibial tuberosity. We can feel the tibial tuberosity. If you are sitting, we can feel these structures. We can feel from patella to distal to patella. Distal means away from heart. We can feel the patellar tendon, and it is attached to the tibial tuberosity. Tibial tuberosity. These bony points are of very much importance. And whenever there is a tear in the extensor apparatus of knee joint, which may occur if there is a tear in the quadriceps tendon, whenever there is a tear in the patellar tendon, and whenever there is fracture of patella, that means displaced fracture of patella. In these three conditions, the patient is unable to do the extension. Whenever we ask the patient to do an active SLR, it's important. Whenever we ask the patient to do active straight leg raising, the patient is unable to do active straight leg raising whenever there is tear in patellar tendon, quadriceps tendon, or displaced patellar fracture. Whenever a patellar fracture comes to us, the first test clinical examination to do is whether the patient is able to do active SLR. If the patient is able to do active SLR, that means the extensor apparatus is patent. That means it is possible to do the conservative management for that condition. But if the patient is unable to do active SLR, that means there is displaced fracture of patella. And in that particular condition, in the displaced fracture, actually it's an avulsion fracture due to the pull of quadriceps tendon and patellar tendon. In such conditions, the patient should be referred to an orthopedic surgeon for the surgical management for K-wiring. And another fracture of patella is comminuted fracture. That means churnida bhatna. There will be so many small pieces. In that particular condition, it is better to go for tension band wiring. Why? Because that particular small pieces of bone won't heal. So that patient, that comminuted fracture patient also should be referred. But if there is undisplaced transverse fracture of patella, that means Kanda Bhatna, if it's undisplaced, it is possible to do the management with 3 to 4 weeks immobilization above knee cast, or we can do complete rest with a knee immobilizer. Within 3 to 4 weeks, it will heal. The only fracture in patella we can manage is undisplaced patellar fracture. If there is displacement, it should be referred to an orthopedic surgeon. Why? Because it is due to the pull of a muscle and we can do proper reduction. We can't do proper reduction if it's displaced due to the pull of a muscle. And another condition, congenital bipartite patella. It's a congenital condition, but look like fracture. Whenever we took an X-ray, it looked like fracture, and it mostly is seen at the supralateral pole of patella. Supralateral pole of patella, we misdiagnose it as a fracture. It's actually a congenital bipartite patella, and in that condition, we want to check X-ray of normal knee joint also. Whenever it's a congenital condition, it will be bilateral. So that to check whether it is a congenital bipartite patella, which is seen in the supralateral aspect of patella, in that condition, we can take a check X-ray of the normal knee joint to check whether it's a congenital condition. Hope you understood what I said. In a congenital condition called congenital bipartite patella, if we took an X-ray, we misdiagnose it as a fracture. So in that particular condition, we can take the X-ray of other knee joint also to check whether it's congenital or not. In this picture, please note these structures. This is lateral collateral ligament or fibular collateral ligament. This is the lateral femoral condyle. This lateral femoral condyle, that particular point is that understanding of that particular lateral femoral condyle is of very much important in the management of or in the diagnosis of iliotibial band syndrome. It is attached to the proximal end of fibula. I already explained that in this particular injury, there will be avulsion fracture due to the pull of lateral collateral ligament. There will be fracture to the proximal end of fibula, which may cause injury to common peroneal nerve, and that common peroneal nerve injury may cause foot drop. So that particular injury is of potential risk. So please keep in mind. And this is quadriceps tendon, patella and patellar tendon, and this patellar tendon is attaching to the tibial tuberosity. The tibial tuberosity, that particular point, please note, these structures are of very much importance in the understanding of patellar tendinitis. Patellar tendinitis. In age group 12, there is a chance of Sinding-Johansson-Larsen syndrome, in which there will be pain at the distal end of patella due to the pull of this patellar tendon. Whenever a person is doing sports at the age of 12, then there is a chance of Sinding-Johansson-Larsen syndrome, which we discuss in the later slides. I am just addressing the importance of applied anatomy. Whenever there is a pull due to the patellar tendon, the patient felt pain at the distal end of patella, and that age group is of 12. And if that particular patient is continuing with sports activities, and then there is a chance of Osgood-Schlatters disease at the age of 50. That is due to the pull of patellar tendon at the tibial tuberosity. And the cause is same, but the point differs from the distal end of patella. The pain changes to tibial tuberosity. And the same patient continues again sports in between the age of 15 to 30, there is a chance of patellar tendonitis. In patellar tendonitis, for the diagnosis, it is better to ask the patient to flex the knee joint and ask the patient to extend the knee joint against our resistance. Then patient presents pain at the patellar tendon. And just posterior to patella, there is prepatellar bursa, and in the both sides of this patellar tendon, there is infrapatellar bursa. And in housemates, there is a chance of prepatellar bursitis. And in clergyman means priest who are kneeling long hours as part of prayer, there is a chance of infrapatellar bursitis. So all these structures we should know definitely for the proper understanding and diagnosis of the disease. Please note, in this picture, we can definitely see that the medial collateral ligament is closely attached to medial meniscus, but this lateral collateral ligament has no attachment to the lateral meniscus. But the medial collateral ligament is closely attached to the medial meniscus. This is the femoral condyle, medial femoral condyle, and into the medial femoral condyle, this medial collateral ligament is attached, and when compared to MCL and LCL, more chance of injury is to MCL. When compared to ACL and PCL, more chance of injury is to ACL. When compared to medial and lateral menisci, more chance of injury to medial meniscus. And this medial meniscus, MCL and ACL tier is known as unhappy triad. And please note, this medial collateral ligament is closely attached to medial meniscus. In medial collateral ligament injury, more chance of injury is at the femoral attachment, in its femoral attachment, if there is medial collateral ligament injury. This is the tibial tuberosity, and the patella, from the patellar tendon connects to the tibial tuberosity. This is the inner part of medial collateral ligament. Here we can see the medial capsular ligaments, which is situated more closer to the medial meniscus. Please note, this is the medial capsular ligaments, which is situated inside the medial collateral ligament, which is more close to medial meniscus. Okay. And please note this pes anserine bursa, which is situated at the medial aspect in two conditions. That means if a patient with long history of osteoarthritis, there is a chance of pes anserine bursitis associated with it. And also pes anserine bursitis may associated with a patient who is more walking uphill and downhill. And this pes anserine bursa is the attachment point of three muscles. And another thing is, to diagnose the pes anserine bursitis, the patient felt pain 2 to 3 centimeter distal to the medial joint line. I will explain the medial joint line in the further slides, how to diagnose pain in the medial joint line. And 2 to 3 centimeter distal to this medial joint line, the pes anserine bursa is situated. And this in pes anserine bursitis, surely we can elicit tenderness, but to confirm the diagnosis of pes anserine bursitis, we can do another clinical examination test. I will explain it. The patient is in prone position. And the patient's knee is flexed to 90 degree, and ask the patient to again flex the knee joint from 90 degree against our resistance. Ask the patient to flex the knee joint again in prone position from 90 degree against our resistance. Then the patient felt pain at this pes anserine bursa. And this is pes anserine bursitis.